lately. Not everyone has done it yet, I think. Have you tried it already?
I've done it once.
Okay.
Oh.
So it's kind of, you need repetition to
I
get
did twice.
the technique right and all
It's a
that.
good experience. Actually,
Sure, when you-
it's a really a good experience.
Yeah, so basically this Hanna is called a fracture table because they were doing this for like nailing and all that intertrachonic fractures. But eventually someone decided, oh, we can use this for for a deer hip. I think his name is Dr. Joel Maddox or something. He's from California actually. So that's why they were doing the anterior approach, which is during supine compared to majority of our cases where they're lateral. So the main advantage of this approach is you're not cutting any muscles. You're just kind of going away through the natural, spaces within the muscles. And another advantage to that is afterwards during physical therapy, it's more stable compared to when you cut it. You have to kind of make it heal before you actually give them more rigorous physical therapy. And since it's more stable, they can ambulate quicker. There's not much feeling when it comes to the cutting that you made from the other approach. And basically, I'm just gonna do a quick from the start setup to eventually how we're gonna manipulate this. We probably kind of know a little bit about the parts, right? And we're gonna discuss a little bit more on this side because for safety reasons, when we start the case, that's the first thing that we need to check. First things first, before you even connect. This is called the leg spars, by the way. And this is like the bed part where it has the base and everything as far as control is concerned is over here. So for safety reason, the first thing you need to do is to lock it, especially when you're about to put the spars. You want to lock every single leg there and make sure that you have power. There's a remote control over here that basically has just 6 functions. So raise the bed, bring it down, tilt it left and right, and trend and reverse trend. So that's it. Whatever you see on this control, you'll also see here on the main panel over here. There's another control panel over here, and that's why we're talking about safety. Because in the case where there's no power, you can't make this work. If this won't work, try what's over here. I don't know if you can see this one here. If that still don't work, try to unplug, check if it's your plug. And if that still doesn't work, there's a knob here, a red knob, that you're supposed to reset the whole thing. And that still doesn't work. There's some circuit breakers over here, like 3 circuit breakers, where you have to push everything down and then depress again to put it back. Hopefully that works. So another important thing about the power as well that you check, because this lift, which I can't recall if we use this for nailing, do we?
No.
No, right? So
Just the anterior.
So for especially for anterior approach, we want to make sure that this works. There are times when you can't make it work, and I kind of noticed that sometimes the reason why it's not work, there's some kind of like salty, dried up thingy there. I don't know what the dried up material, so just wipe it out, and then we try it again, because it's not a good thing when you already started everything and this one works. They're not gonna like that. So the basic setup for the anterior approach, arms are out compared to the nailing where the other one is crossed, right? Both legs are there, both leg parts are there compared to the other one where the well leg is on the leg assembly. And And arms out, this one in, depending on the side of your procedure. There's another I forgot what this is
Extension
called, but there's
pulse.
a thing here for the Omni that you put on the opposite side of the surgical side. And this is just to connect the Omni later. You also want to make sure that you put the femur lift on the correct side as well. So test everything, need to connect the control, test everything, and if everything's okay, then it's a good time to put this on. We'll be showing, this is a two-person maneuver. Probably can be done by one person, but it's not safe. It's not recommended. So when you're putting this on, there is a safety mechanism here. Where's that at? There. Yeah. And you know when it's locked because there's a clicking sound that you can hear. Or if you can't hear it, it's supposed to go down as well. So on some of the videos that I watch, they want this up before you put the whole legs bar in. They want that up, so that kind of releases, opens up the inside. But you'll still be able to actually push it. It's just gonna go down and up and down. So that's the first safety check in putting this in as well. They also recommend that you test this by jiggling it. And if you see some movement over there, the suggestion is to, when you lock it from this knob here, that there's no gravity. So you have to hold it to lock it. And this part over here is where most of us the nurses are gonna concentrate on, because this is the part that we will eventually be doing ourselves in an ideal world. So this part, you're probably familiar with this, right? There's traction, there's rotation.
Put that knob in on the safety knob on the side.
Which one?
The safety knob on the side.
Unlock.
Oh yeah, you have to lock
To
it.
lock the safety knob.
You're right, right? You know, right inside you know, yeah, so that's it. And where was I, Dwight? I got lost.
Oh, you have to have the bottom part. Rotation.
Oh yeah.
Rotation.
So this is gross traction over here, and this is fine traction over here. There are certain maneuvers at certain part of the surgery, which we will be discussing later. The rep's supposed to be here anyway to show us this stuff, but we kind of know how to use the functions of this. It's just a matter of what combinations of maneuvers do we need at a certain part of the procedure. Because I think for me, when I was doing the anterior approach, that's the main concern. Like, if I go there, what am I gonna do? Because we're busy charting, right? So if they ask you, sometimes the surgeons didn't hear what they want, you know. So there are certain terminologies as well that we need to learn that some surgeons might use and might not. So when you bring this whole leg bar down, it's actually called leg extension, but you won't hear them say that. You would normally hear them say, drop the leg, bring down the leg. I've had a few other, I had it here. So that when you get there, whatever you hear, so you know that's what you're supposed to do. And I know we're gonna be going through the details later, but I just can't stress the fact that when we're bringing this leg down, that there's no traction. That's probably, yes, go ahead.
Whenever the patient is on this table, and you got the legs in these spars, those safety knobs have to be loose. They have to be loose. Otherwise, if something happens, somebody, when you hit one of the knob, there's an knob there, if they fall down, you're gonna break the leg off the patient. So these things are geared to slide. So So if that bar should drop, it'll slide back to the end, and it won't break the patient's leg.
Especially the nerve, I think that's the one that they're
Whenever,
concerned.
what you doing,
This is the one that
yeah,
the
that was right
lotion-
there. Whenever you got a patient on the table, whether you're doing a nail or whether you're doing anterior approach, these things have to be loose. Until the doctor starts to tighten them, they have to always be loose. If you put them on the patient on the table, you have to make sure that they're loose. If it causes severe injury to the patient.
Yeah, so the knobs are basically, you know, it's universal that you're doing it righty tighty and lefty tighty. But when your orientation is from this side, you can easily get confused which one, you know, because it's the only same thing as far as knob is concerned is this one and this one. But this one, like when you're bringing it down, right, tighty, right? But you're doing it that way instead of this way, so your orientation is can be confusing. So when you're doing this one, oh, you also want to make sure that when you connect these legs, that these knobs are on the lateral side, on the outside, because it's just easier for you to instead of grabbing it from the inside. So
But it's always there. They never.
no, because you can
You
put
do
this
it
one on that side.
backwards.
You
Oh,
can
yeah.
by mistake put it
Oh.
on that side.
Oh. It's
So-
happened. Oh yeah.
So
okay.
like this one, when you're releasing, you're doing it this way, right? Towards you.
Okay.
But this one, when you're releasing it, you're away. So just a little thing that might get you confused, you know, because it's not they're not identical. Like both are on different sides. Unlike this one, they're in the middle. This one cranks the same, you know. When you tighten it, it's still the same, right? You know. And there are certain parts in the procedure where we need to use this, and as far as I'm concerned, there's only one time that we need to crank it. So as far as the anterior approach, setting up the patient when the patient gets in the room after having their spinal done. I don't know if I'm supposed to discuss this, but we know that we need to put the boot first, right? So we need to wrap it with the web rail on both, and the surgery side needs to have a co-band. That one's to prevent slippage. The web rails is to protect the patient from injury, from pressure. Yeah, so transferring the patient is a 4-person, you know, job. So there's one on both sides, and there's somebody who's going to be holding the leg. They can be here on the inside, and this part here as well. Before you even transfer the patient, you want to make sure that this part here for the fine traction is all the way, so you'll have enough space. Because once you put it over here, and then you position the patient, you only have this much to do the traction, right? So make sure once you do that, you set this thing on 0. There's a small screw thing here that you can release it, so you can put it on 0 once you lined up everything. And you might be wondering what this red zone is. Do you know that?
Red zone is as I was telling you before, the travel of the patient. When the patient is in stirrup, this whole area right here is considered the red zone because if it's locked, the patient's leg is locked, then this thing can fall. It's going to break.
Oh, so the
And
red
that's why it's
zone.
considered the red zone. Because
The red
that's
zone
safe
is
there.
actually once you're positioning the patient's leg and go all the way here just so you can put the patient over here. That means the patient is too short, and that's not gonna work. That's why we need the extension. So when you put the patient's leg and you're all the way up here, it's not gonna work. You're not gonna be doing a lot of traction anymore. So that's why you need to put the boot on an extension like this. So that's the main purpose of like, oh, red zone. So I need to put the extender. And what else? For when transferring, we need a roller. And once we get the patient in, one safety thing that I've read and what Dr. Kandabi has always been saying as well is to immediately with this, that just puts the patient in a safe position. And once you're there, you have to pull the patient all the way down. And then once you're set up with this, then you don't have to lock anything over here at the start of the case. So now that we're ready, they'll take an X-ray. For patients who are big, they tend to pull the fatty part of the belly to the side, tape it, so they just have access. And once we're done with X-ray and we're ready to drape, Sherwin will explain to you the Omni part because before we start, they would set up the Omni positioners already. After we did, yes, right.
If you're a nurse, and as soon as you got safety strap on that head,
Yeah.
I'm gonna tell you right now, even though that foot tube, the leg thing is there, you know, the patient just don't fall. I know, a lot of people want to put a safety strap back here, it don't work back here. So, I put the safety strap on these struts right here. You can still move one strap, just one strap.
Oh, one
Because this one goes across the abdomen. It goes across the abdomen.
Right. This comes with its own strap. Do you remember where they put it before?
No, I don't.
It's there, but I don't know which part you put it.
Well, it's supposed to go across all the way around the patient.
Yeah, but where specifically?
No, it's supposed to go around the patient. There's no place for it to put on.
You can put it anywhere.
You can put it anywhere. You can put it anywhere.
But it's still there, but it looks
But
like it's...
I recommend that you put the safety straps here. You can still mobilize these arms any way you want. As long as the safety straps are on here, because if this patient hits the floor, guess what? There's no excuse. No excuse. And what happens is after the case, everybody's screwing around, especially the doctor. First thing he does is take that thing out.
Yeah.
If he takes this thing out, guess what? That patient's on the floor. I don't care who's back here. If the patient's too big, he's gonna fall. Okay, so safety strap on this patient will keep him from moving off this table. Okay, even if the doctor takes this part off, he'll get caught like this with his leg hanging off. At least he's not on the floor. Okay, if his legs are hanging off, that's okay. You don't want this part to go off the ground. So that's it. He's done. And this is pretty high up. This table is so unsafe. And if you're not safe with it, guess what? Your license is out the door. I'm telling you, your license is out the door. Goodbye.
So Sharon's
Thank
gonna take over.
Wait.
Dramatic effect.
Where do you position the X-ray? Does it go
Opposite side.
perpendicular or an angle?
Perpendicular.
Perpendicular.
They just go straight like that.
Why is there a weight there?
Demonstration.
To
For demonstrate-
simulate a leg.
Okay.
And this one's to simulate traction where
Okay.
You don't need that weight there for the case.
Oh, okay. So just to add on to, because I know that the main problem right now is the rep doing all this work, and it's changing that the nurse are going to do it now. So basically on this, like what Ben said, this is your growth traction. It needs to be open, okay? This is your micro traction. Gross micro needs to be like all the way up in order to do that. And usually this is not just for the anterior. When you're doing a hip pinning or nailing, you need you need to learn all that stuff.
Usually they said abduction.
Yeah. So rotation, you have a certain degree here. Okay. They'll tell you what. I mean, pretty much. Okay, can you do it? Put it on 120. Put it on 120. Close it. If you want micro traction, you can see this one, micro traction going in, right? So this one is the gross traction, and this is the most important thing, is when you're dealing with the whole leg. When you need to drop the leg, you need to hold this with everything you got, especially if it's a big patient. You unlock it, and either you bring it down,
Loosen.
off, yeah, abduct, deduct, and do all that, whatever he wants. But don't let go. So make sure you lock it. And like what Dwight pointed, this is an extra safety. Okay, this is locked. With that,
So, the other thing is, when you're talking to the doctor, and he's telling you abduction and rotation, so sometimes you'll say the same thing, AD or AD.
Which kind of doesn't make sense because they sound the same.
They sound the same.
They
So
sound
you
the
have,
same.
you have to repeat AD or AB. Which one is it you want? AD or AB?
Dog or
Because
boy?
One takes it into what the patient, the other one takes it away from the patient.
yeah.
Okay?
Okay, so when we're doing the, so this will be on the patient's foot, right? And usually you do it on the bedside. When they transfer the bed, there's actually an extension right here for safety. You don't want this on. There's a thing here, you can bring this down. And what, I was looking for that. You know, that part.
The part of the bed.
Because when you move the patient, it needs to be flat.
It's right
Oh, no, we don't do that.
No, like for
Yeah.
kneeling.
Yeah, it's okay. It's okay.
This is what I recommend. If you want to nurse it and you finish to take the patient off the table,
Dwight approach.
take this part here, put it here. Put it here, legs go here, and you say, okay?
No. Please, don't do that. Because the body is right here, the leg is down there, it's no way, especially the
No,
leg
no,
will
show
be
me.
sitting here. Okay, and if you're limited in
Cut,
time.